So it is very much in this vein that they are proud to be partnering with the Australian Friends of Rambam, the Jewish Folk Centre, and bringing you this important series of prostate cancer. With the very high caliber of speaker in Dr. Thomas Harass, I'm sure you'll find tonight's talk very stimulating and informative. Over to you, Vered.
Thank you. Thank you, Darren. I'm moving now to our other, she's not here. Miri, are you here?
Hi, yes.
Okay, so I would like to introduce you to Miri Ordan. Miri Ordan, President of the Jewish Folk Center, the other, our other partners for this event. So Miri, please, the stage is yours.
Thank you. Thank you. Welcome, everybody. Welcome, doctors and everyone from all over the world. With all the technology, we still have a little bit to learn, but we're getting there. I just want to thank everybody and thank Vered especially and everybody else from Rambam for the last few weeks of amazing lectures. And I'm sure we're in for a special treat tonight as well. So thank you very much to Dr. Tomer. I'm not quite sure how to pronounce your surname. So
Charas is fine.
How to say it?
It's spelled Charas, but we just pronounce it Charas. Yeah.
Charas. Okay, Yofi. Dr. Thomas Harass, thank you very much to you tonight as well. Okay, enjoy everybody.
Thank you, Miri. Okay, I would like to introduce you now to Dr. Philip Bliss, our moderator for tonight. Philip is currently the president of Progressive Judaism Victoria and treasurer of the Australian Council of Christians and Jewish and Mancreek Lanker. Philip has previously been president of the Union for the Progressive Judaism and vice chair of the World Union for the Progressive Judaism, and now an honorary life member. Philip was president of the Jewish Community Council and chairman of the Council of Christians and Jewish Victoria. He is retired dentist with 4 children and 7 grandchildren. And Philip, I'm moving it to you. You go.
Thank you, Vered, and welcome everybody. It's my pleasure to introduce our guest speaker tonight. Dr. Thomas Harass serves as the head of the Genitourinary Oncology Unit at the Oncology Division in Rambam Health Care Campus in Haifa, Israel. He's a board-certified radiation oncologist specializing in radiation therapy treatments of the genitourinary tract cancers, including prostate, bladder, kidney, and testicular cancers. Dr. Charas graduated from the Semmelweis University Medical School in Budapest with honors. After completing his radiation oncology residency training at Rambam Health Care Campus, he completed radiation oncology genitourinary fellowship program and additionally the Brachytherapy fellowship program, both at the Memorial Sloan Kettering Cancer Center in New York. Dr. Charas is highly involved in prostate brachytherapy, which is the implanting of radioactive sources in the prostate, very involved in research and implementing new technologies aiming to improve patients' care and reduce side effects from treatments. Dr. Harass is a member of the European Society for Research on Cancer Treatment, the American Brachytherapy Society, and the American Society for Radiation Oncology. Ladies and gentlemen, Dr. Thomas Harass.
Hi, everyone. So thank you so much for the kind introduction. I'm just going to start by sharing my screen. Hopefully everyone can see. Yes. Okay, so again, thank you so much, and thank you for the organizers as well. It's a great privilege for me to be able to speak to you. Also, thank you for our audience being thousands of miles away. So we somehow overcame all the technology barriers that we had. But now we'll probably be able to go ahead and talk about today's topic. So how advanced technology helps us with treating prostate cancer. in addition to helping us stay connected to our colleagues overseas. I want to give a huge thank you for my coordinating nurse, Miss Alison Berlinger, for assisting me with the slides. So let's see if I can, this works correctly. Okay, so I have nothing to disclose. So we'll just start by reviewing prostate cancer and radiotherapy, what that is. Maybe some of you already heard the 2 previous talks about prostate cancer, so this might be a repetition for you, but actually what radiation is and how do we implement this with prostate cancer and what we are about to advance into the near future and the far future. That's going to be the second part of the talk. And obviously we're going to have a short while to discuss and have a Q&A. So prostate cancer is a very common disease among cancers. This is a slide from the US registry. So prostate cancer, you can see on the top part of the slide, is the most common cancer diagnosed among men. And it's second most common or second most related cause of death among cancers. Again, in men, second only after lung and bronchus cancer. So it's a very prevalent disease in the US and in Israel as well. As you can see, it's the most common cancer in men. When we actually divide the registry into Jews and Arabs, for Arab males, this is the second most common cancer after lung cancer. The registry here is updated up to the 2012 or 2013, was recently updated, but we don't have the numbers yet, it wasn't published. So again, in 2012, we're talking about almost 2,500 new patients diagnosed with prostate cancer. In Australia as well, your registry is more updated. This is the 2019, the numbers from that year. And we're talking about, you can see this is the most commonly diagnosed cancer. If we're talking about males, this is the most common diagnosed cancer among males from the age of 50 all the way up to the age of 85 and above. And for all groups, so male and females, we're talking about this is the most diagnosed cancer in the age of 60 to 75. So definitely a very prominent disease, very prevalent disease that we need to address. So again, going to the basics, anatomy, what's the prostate, where is it located? So this is general schematics of the male anatomy. This is what we call a sagittal cut, so a midline cut of the male anatomy. The prostate, you can see here, is this orangey shaped organ, which is located deep in the pelvis. And right above it is what we call the urinary bladder. So this is the bladder that holds the urine. And the urine flows out through the urethra, which runs into from the urinary bladder through the prostate outside. So this is actually an important part of the fact that the urethra, this is the tube here that leads the urine, runs through the prostate, does affect how we treat the prostate and how patients are affected by the treatments and the cancer itself. You can also see that the rectum, which is the last part of the bowel, is located right behind the prostate, more backwards. And if the physician wants to palpate or touch the prostate, he can do it with a rectal exam. So that's a way for a physician to evaluate the prostate of a patient. In general, we describe cancer. This is like a one-word disease, but it's actually a variety of diseases. So what is common to all of those diseases, obviously, one pattern, which is a one cell that is uncontrollably dividing. This happens because of some mutations in the genetic material. And eventually this uncontrolled division leads to tumors, leads to masses of cancerous cells. And those masses can either infiltrate the surrounding tissues, the healthy tissues, or it can affect distant tissues, what we call metastasis. So a tumor will grow out additional tumors, which will be located further or at a distant part of the body. And this is called metastasis. And when we talk about prostate cancer, we're talking about the same mechanism. So there's a cell which divides uncontrollably and causes this cancerous mass. And we divide it to different stages, obviously from the earliest stage to the most advanced stage. Stage 1 being the earliest one. You can see again the prostate here. It is located again below, or right below the urinary bladder, which is delineated here in sort of like a pinkish color. Here, this is the prostate in orange color. And you can see here in yellow, this small part is the tumor. It is in stage 1. It's still all confined into the prostate. And when we talk about stage 2, we're talking about multiple tumors all still confined into the prostate. When we talk about stage 3, we're talking about a tumor which already spreads outside from the prostate. So either it reaches out the healthy tissues that are found beyond the prostate outside the capsule, or it invades adjacent organ. For example, this is the seminal vesicle, an organ which is adjacent to the prostate. So again, invasion of the tumor outside the prostate would be considered a stage 3. And the most advanced stage would be a stage 4, in which we can see here in this illustration, those lymph nodes that are located further away. They could be in the pelvis, but even for a distant, even in a distant area of the body, those lymph nodes will be affected by the cancer, and they will have cancer in them. So stage 4 is when the cancer is progressed into a stage where it is further even beyond the prostate itself. We can't really discuss prostate cancer without talking about PSA. So what is PSA? Yeah, the acronym stands for prostate specific antigen, meaning this is a protein. We can measure that level, the levels of that protein in our blood. And it is very specific to the prostate, meaning only prostate cells actually secrete it or produce it. So whenever we measure that in the blood, we can, from that, infer, we can also deduct that there is a problem or there's an issue with the prostate, specifically if the levels are abnormal. PSA levels could rise if there is what we call a BPH, or it's a benign growth of the prostate, benign prostatic hypertrophy. So this is not cancerous growth, but a benign growth, but still it can cause increased PSA in the blood. Also, any kind of pathological condition in the prostate, infection or inflammation, and obviously cancer can cause elevation in the PSA. A lot of patients are very concerned when their PSA results come back and they're sort of like not within the normal range. I always try to reassure patients and our urologist colleagues as well that PSA levels are not enough to actually diagnose patients with cancer. They can only slightly indicate that there might be an issue with the prostate. You have to have a biopsy or a sample of the tissue to diagnose the cancer. PSA is very valuable, though, when we're talking about following patients after they had treatment. That treatment could be surgery, it could be radiation, but in any event, following the PSA after the treatment might be a very effective way to try to, following the PSA after the treatment would be a very effective way to try to understand what's the condition of the disease. Has the disease recurred, or has the disease progressed after the treatment? And talking about prostate cancer as one disease is not a correct way to put it. There's actually a spectrum of diseases even within prostate cancer, which we don't see in other cancers as well as we see in prostate. And I always tell my patients that while we see those two as two cats, those are two very different cats. You may put them in the same family, but they're not the same thing. So one you might want to have in your house, but one you definitely don't want to have in your house as a pet. So again, talking about prostate cancer, we always have to look at the aggressiveness of the tumor. So not all prostate cancer are alike. And we try to evaluate how aggressive prostate cancer is by looking at the PSA level of the patient, but obviously looking at the T stage of the disease, which I've mentioned in the previous slides. And we also look at what we call the histopathological assessment. So that's the actual sample of the tissue taken from the tumor, and that tissue gets a score. It's called the Gleason score, named after an American pathologist. Eventually that score, that number, will also indicate to us how aggressive the disease is. So we take those factors, also other factors into account when we try to estimate how aggressive that tumor is. And once we've diagnosed the patient with either prostate or other cancers, we only have 3 things we can do today in our medical community as a whole when we treat patients. This is what was given to us by God. Basically, it's going to be radiation, medication, or surgery. We don't have anything else that might help us, to treat patients with cancer. Some cancers are very well treated with radiation, some are not. Surgery, same thing. Medication, same thing. So Different cancers are treated by different modalities, either radiation, medication, or surgery. And the major questions that today we ask as physicians when we first evaluate a patient: what's the optimal treatment for that patient? Do we need to combine? Is radiation following surgery will be a better way? Should we involve radiation with, should we incorporate radiation with medication when we try to treat a patient? So those are the major concerns or major questions that we ask nowadays, how to incorporate all those three modalities into the best outcome for those patients. What's the timing for that? What's the order for that? It's not always easy to assess. So let's talk specifically about radiation, because that's most of our talk today. Radiation is, while it gets maybe sometimes very bad publicity, I tell my patients that radiation is either good or bad. Radiation is basically a form of energy, same as light or the same as heat. Probably the bad publicity for radiation comes from the fact that we don't sense it. There's no way we can, as opposed to light or heat, we don't know if we are affected by radiation. So even patients that are going through radiation treatments, they don't feel anything from the actual radiation treatment. And radiation itself physically behaves either as waves, packets of energy, or some sort of particles with mass. I don't want to go into too much of the details of the physical aspect. From biological or medicine aspect of it, I just want to emphasize the point that when radiation hits the cells, when radiation affects the tissue, it damages the structures, and cells have different structures in them. The most important one would be the DNA. So that's the genetic material. So when the radiation damages or hits the cell, it will affect the DNA. And that damage to the DNA will eventually leads to either immediately or later on to cell death. Obviously, we want to do that when we want to treat cancer cells. We don't want to do that when we talk about radiation exposure or radiation safety. We want to avoid that damage to cells. So how can we benefit from radiation? Like I said, radiation itself does not differentiate. It's not good or bad. It just affects cells. But there is a difference between healthy cells and cancer cells. This comes from different properties of the cells themselves. So when cancer cells are hit with radiation and they have a DNA damage, their genetic material is mutated, is damaged, they're mostly unable to repair it because they have a lot of aberrant pathways and they have a lot of abnormal behavior. So they're unable to repair the damage. While the normal tissue, the tissue that's surrounding that, those cells will survive because the normal cells of the body are capable to some extent repair and regenerate themselves. Obviously, when the normal tissue is affected, this is where we have the side effect. It's not from the cancer cells or not from sensing the radiation. The side effects comes from the damage to the healthy tissue that is usually surrounding the cancer. So looking at this slide, this is basically my entire residency summed up in one slide. So we want to harness this huge amount of energy, this radiation, into hitting correctly and properly the actual target. So we'll evaluate radiation treatment as being successful when we deliver a maximal dose of radiation to the cancer cells and when we actually deliver a very minimal dose of radiation to the surrounding cell as much as possible physically and biologically. And the way to do it and technical advances that we've made in the recent years allow us to do that, and I will elaborate about a few of those in the next slides. Like I said, prostate cancer is a variety of diseases, so we don't look at prostate cancer as one type of disease. We look at it from different risk perspective, the bad cat and the good cat, but as a whole, radiation is very effective in all those types of cats. So in all those risk, the low risk or the high risk diseases, the radiation is very effective. So when a patient has a low risk prostate cancer, we usually tend to not treat them at all, but if we want, we can treat them with radiation. If a patient has a more aggressive disease, we term it as intermediate or high risk disease, we can combine the radiation with hormonal therapy. We can combine several types of radiation treatments. And we combine also surgery with radiation as well. In a case where a patient has a metastatic disease, so the disease has spread out from the prostate to the surrounding tissues or distant tissue, we can use radiation to treat either a metastasis, so either a mass that is pressuring the normal tissue or causing the patient some pain. So radiation is very effective from that perspective. And we can use the radiation either as a very specific or specifically targeting the prostate, or to use the radiation as a more generalized area. So we'll use radiation as a more wide area type of treatment. For example, with patients who might have a disease which is spread out, we want to treat larger areas. So not only the prostate, we can treat areas which are just beyond the prostate capsule. And like I said before, we can use it as a combined modality. So a patient who had surgery, and later on that surgery from some aspect has not cured the patient, and the disease had what we call a recurrence. So basically it returned, or it's still persisted within the body. We can use the radiation to use as a treatment, which we call a salvage treatment. So we help those patients as well. And we generally, when we talk about prostate cancer, we look at two types of radiation. One would be the external radiation, which is the most common type of radiation used worldwide. And we might consider also, we should talk about the internal radiation. So that radiation is delivered different. The internal radiation is delivered by what we call a linear accelerator. So this is basically a machine, which I will show some pictures of. And the internal radiation is delivered differently, while the linear accelerator is able to treat the prostate and the pelvis. So the entire area of the prostate is treated. The internal radiation is the insertion of radioactive seeds, so radioactive material which would go into the prostate, treats only the prostate. And sometimes combining those two give us the greatest benefit, because we will be able to give very high dose of radiation to the prostate and use the external with the internal radiation, and then use the external beam to treat areas which are beyond the prostate, which the seeds or the implant of the seeds will not be suffice for. So we might use one, we might use the other, and we might use both of them. So that's a general representation of a LINAC. So external radiation or external therapy, sometimes it's termed as EBRT, external beam radiation therapy. XRT, teletherapy is the old name used. Is given by a machine. That machine is mostly activated by electricity. So basically there's a button, and once the button is pushed, radiation is emitted. Once the button is unpushed, then there's no radiation in the room or in the patient or anywhere else. So same as a light bulb will work. Obviously that intensity of the radiation is very high, so those machines are pretty big, as you can see from this image. This is one of our machines in Rambam, so that's a linear accelerator, and basically the machine can turn around. This is a 360 degrees rotation type of movement, and the radiation will be transversed through this part here, which is called the gantry, and then emitted straight down, 90% angle down towards this table here, where the patient will be, and I'll show a picture of that a little bit later. So that's a linear accelerator operating or delivering external radiation. This is, I will have to say, the comment the Australian authorities for the distribution of radiation therapy accelerators throughout the continent or throughout the country. And you can see that mostly those that sort of like pinkish color represent a well-balanced enough or good numbers of machines, while other colors might represent either over installation, so more treatments or more machines installed than needed, and the green parts I think is under, so a few machines are installed. So mostly, I would say for most of the country, enough machines or a proper number of machines are installed. So those machines, as you can assume, are quite expensive to buy and to operate, and there's a financial aspect to that treatment as well. A few more things about the external radiation. So those machines, those accelerators emit, like I said, very high intensity radiation. So that means that for radiation safety, they will have to be located within a bunker, a fortified bunker. The walls are very thick. This helps to absorb the radiation and make sure that there's no radiation outside those rooms. The actual treatment itself lasts for a few minutes. Like I said, the radiation, the machine rotates, and I'll show a short animation about that. But even though the treatment is short, sometimes it has to be repeated over and over again. This has to be done to achieve the maximal effect. And positioning the patient is key. So you have to make sure the patient is correctly positioned, and he has to be fixated so nothing moves during the treatment. So this is one of our key rules for the patients when they're taught before treatment, is not to move during the radiation treatment itself. And like I said before, it's like a light bulb. So it goes on and off. Once the radiation is done, then that's it. There's no more radiation within the body or within the room. So it's safe. So this is a short animation. I'm not sure. I hope it's going to work. So looking at the prostate, what we would do is that we would capture it on a computer, and then we'll take those animations and then sort of like create a plan. And then that machine would rotate around the patient. Obviously, you won't see those beams. Those beams are just the illustrations. You cannot really see the beams. So the machine would rotate around the patient. So going back again, we capture the images, we build a plan, we have a radiation plan, and then that plan is delivered by the machine, which sort of like I said, rotate around the patient and aim at the target, in this case, obviously, the prostate. So this is what a radiation treatment plan looks like. So the computer gives us this color scheme showing the red color is a high dose. The numbers are located on the left side of the screen. So a very high dose is delivered to this part. This is the prostate. This is what you see actually a CT scan, which, and then we superimpose the plan on those scans, on those images. So again, the prostate here, this part gets the red dose, or like red as in high dose radiation. And this area here get the medium dose, or green, and the rest of the areas get very low dose. So this is represented as a blue color. Actually, the blue color, being a low dose, doesn't really affect patients or the health or cause any side effects. It's mostly I would say the red and the greenish part that affects patients. And we'll talk about side effects later on. This is another illustration, I think pretty much about the same thing. So again, the table where the patient is positioned can be moved and can be elevated, can turn around. There's a lot of degree of freedom there, and the machine itself rotates. It doesn't touch the patient. There's a safe distance of at least 30 to 40 centimeters, sometimes even more. And within actually the head of the machine, you can see what we call a multi-leaf collimator, which is a collimator, basically a shutter that closes and opens and creates different shapes. You can see that as while the machine is turning, different shapes are being formed. This allows for different radiation fields or different radiation types and beams to come from different angles. And this allows for obviously a much better anatomical matching. So if a patient has a very weird kind of shape of tumor, we can match that with that collimator. What about the internal radiation? So the internal radiation, the professional, the terminology for that would be brachytherapy, if you want to Google that, or if you check your physicians. Brachytherapy basically means brachy comes from Greek near or close. So it's a nearby therapy. In French, they call it a Curie therapy, named after Marie Curie. So basically it means having radioactive sources placed either within or very close to a tissue. So we're not talking about electrical big machine which works. We're talking about actually very small seeds that are inserted. And when we talk about prostate cancer, they're actually inserted under general anesthesia. So that's about 1 to 1.5 hour procedure. When we place very accurately those seeds within the prostate, we do it with a sort of like an elaborate setup that you'll see. And these distribution of those seeds allow us to give radiation to the prostate. So it allows for an optimal dose to the areas that we want to treat, like the prostate tissue or the tumor, and we try to avoid and reduce the dose to organs that are nearby, like such as the rectum or the urinary bladder. the radiation is actually very short term, so there's nothing emitted, almost nothing emitted from the body in most cases. So like I said, this is a procedure which is done under general anesthesia, and we have this ultrasound probe that gives us image of the prostate. And once we have a live image of the prostate, we will put the needles through the skin and into the prostate, and then we will use those needles to insert seeds. So this is what it looks like in real life. Obviously, you have a patient, everything is sterile, and those are the needles that will act as guides, and the seeds will go through the grid into the prostate, while we always keep an eye with the images, the ultrasound images, to see what we're doing. And then the computer will sort of like give us an estimation. It's a very accurate estimation about our dose. So we don't just randomly throw the seeds in. We put them in a very specified locations in order to give this cloud. You can see this line, this cloud of radiation, and then we can see it through each slide. And obviously at the end, the computer will also give us this 3D image that sort of like shows us where the prostate is and where the seeds are, each seed is located. And we also have a CT scan done. This is done after the procedure, just to make sure that everything is okay. And the computer will give us all these numbers, these sort of like the symmetric evaluation of have we, sort of like answering the question, have we given enough radiation, or have we given over radiation? Have we given not enough radiation? And this will allow us to mitigate those in case we have a problem. So that's the staff. Here in Rambam, I'm actually pretty proud to work with these guys. This is a joint venture, not in most cases, I'll say throughout the world, this is not a joint venture. It's either done by a radiation oncologist most commonly, but also by a urologist or by interventional radiologist. But here in Rambam, we do it as a joint venture with the urology team and our oncological team. We have obviously coordinating nurse, Alison, we have other physics team, we have our technicians, we have our QA and faculty. They always make sure that we know what we're doing, and they are involved in educating the next generations. And the fact that this is a joint venture gives the patient, I think, benefits, or the patient benefits from both worlds. From the urology perspectives, obviously from maybe side effects or maybe anything that's related to urological issues, and from surgical issues, and from radiation oncology, it gives the patient the advantages of having the best oncological option. So our program has been going on for over 19 years. I think we started about the year 2000 or so. We obviously advanced as technology advanced, we advanced our equipment and technique as well. We've published our results, and they seem to be pretty consistent with what's given or what's done worldwide, which has a high success rate, and patients are pretty happy with it. It's a painless procedure. It's an outpatient procedure. Patient can, have the procedure started at 8 o'clock, and then he'll be home later in the afternoon or the evening. If we start later on the day, he might stay over and then be discharged on the following day. And if you haven't heard of it, brachytherapy is actually a very well-known treatment, and I'm sure you know this guy, Rudy Giuliani, the prior mayor of New York City. I would, publish this. The New York Times already published that he had that procedure, and you can see that he had that procedure done, obviously, in New York. And just to make sure that I'm not, telling you all sorts of nonsense, Mr. Giuliani was taken to the hospital recovery room by 8:30 a.m. He remained there until shortly before 2 p.m. when he walked easily into the news conference, took a seat at the table between his two doctors, and immediately began a patter of jokes and lighthearted remarks. So as you can understand, even from this example, that this is a relatively easy procedure, one-shot procedure. Patients are really happy. I can't guarantee that every patient will have a pattern of jokes, but at least they will be quite satisfied with being able to go home on the same day. So what's installed us? What do we think is going to happen in the near future, or probably some of it is already happening right now? So we want to make sure that when we give the external beam radiation treatments, we want to make sure that we are very precise. You don't want to put the patient on the table. The patient is fixed, he's not moving, but you're missing by either few millimeters or few even centimeters. and then you'll give the radiation dose to the wrong place. So we want to make sure that we have that precision, and I'm going to show you now how we are doing that. This is a sort of like new advancement. We also want to protect the rectum, and I'm going to show how we do that. And also going to introduce our new kid on the block, the Sbrt. So that's the new modality, what's now being done in major centers throughout the world. So we use this technology or this concept, which is termed IGRT, which stands for image-guided radiotherapy. Basically what it means is that I want to see not only that the patient is positioned correctly on the table, and I don't want to be certain only by teaching the patient. I want to actually image the patient before I start. So I'm going to start the treatment only after I've verified that everything is exactly in the correct position that I want it to be. And I'm most concerned about the prostate, obviously, but also the internal organs, which are the bladder, the urinary bladder, and the rectum. So what we would do is that we would insert these gold seeds, only 3 of them. They're inactive, they don't do anything, but they help us, they show us exactly where the prostate is. So I know that when I match the actual treatment plan that I had with the current position, if the 2 seeds match at the same location, then I know that my beams are going towards the correct direction. And one of the issues that we might have is with the prostate is that the rectum is that they move. I mean, the patient can be in the same location, the patient feels okay, but the internal organs themselves, they move. So what we do is that we actually do an image, a CT image of every patient before they start the treatment. For example, here you can see this is what we wanted the bladder to be on the left side. So the yellow line represents how I planned the urinary bladder to be. If it's not going to be the same way, it's going to be a problem. For this patient, we've scanned him. It looks exactly like we want it to be. But on the left side, you would see that this is the bladder here, right down there. This is not how it should be. This is actually bowel. So what would happen here if the same patient, I would scan him, I would have just treated him right away, I would have actually targeted the bowel or miss somehow the actual target. So I would use those gold markers and I would use that cone beam CT on every scan, and I'm not saying I would, but we actually do it every day to make sure that we treat the patients accurately. So the key word here is to be accurate. What happens with the rectum is that we have a problem. Is that I have a lot of patients, even in the past, say, "Look, doctor, you have an excellent practice here, and you're very accurate with your machines, and you use CT every day, and you use those gold markers. But the problem is that even if you do that, you might still injure my rectum, which is, like I said, the last part of the bowel, and you definitely don't want to do that." And the patients were right, because what would happen is that even if I would, because of the proximity of the rectum, which you can see here, this is the blue part here. The proximity of this blue part to the target, which is the prostate, the red line here, actually makes it impossible for you to treat a very high dose to the prostate and kill the cancer here without even an intermediate dose, even a high dose to a small part of the rectum. So that will lead patients to have, first of all, questions, but obviously later on they might have some side effects from that. And to the rescue came actually 2 companies. There's even an additional experiment going on with that. So few more products are upcoming now. But what we have now today is actually a gel which we inject. We inject it between the rectum and the prostate. This is done by just a needle, done by a very short sedation. The patient is sedated out for 10 minutes. Sometimes we even do it with local anesthesia, so the patient is awake. And we insert that needle and we separate. We just inject a gel. That gel stays there for about, I would say, roughly 3 to 4 months. And that gel separates the prostate and the rectum. That's one of the products that is available today in the market. Let me just quickly go through that. So that's the prostate right here. This is the rectum. You can see they're very close to each other, and any radiation to this area might damage the rectal wall. So what the physician actually does is that he uses the ultrasound. The ultrasound image gives the physician an idea of exactly where he is, and he targets this specific area there. And he wants to aim that needle over there. once the needle gets there, the gel is injected. Well, first we inject a little bit of saline, just physiological water, just to make sure we are in the correct position. And then we inject the gel to make sure that, then we inject the gel once we've made sure that we're in the correct position. So this is when we actually inject the gel. We just quickly skip on here. And this gel, like I said, will remain there. I think we have sort of like a live image of that. That's actually what the physician is seeing. I won't go into too much of the detail, but you can see this is the actual needle. So the needle goes in, similar to what we saw previously, the very nice illustration, but real life is not as nice. You can see here that the physician is now located in the position he wanted to be. This is the prostate. He wants to push the prostate away. So the gel will help or prevent those to the rectum. And then once he's verified he's in the correct position, injection will follow. Let's see if we can see that. I skip forward just a bit. So this is the actual injection process. You can see that there's this bulb created here. And this bulb basically helps the physician to inject later on the gel there and make sure that there's a space. There's an additional, this is an image of how it looks after the gel. So you can see the very high dose now doesn't fall into the rectum. So we have protected the rectum, and the very high dose of radiation just sort of like is given to the gel, which we don't really care. The gel just melts or dissolves, that's the proper term, within a few months, like I said. There's an additional company, an Israeli company, that developed pretty much the same thing, but it's not a gel, this is a balloon. Unfortunately, we have some experience with that balloon. Unfortunately, it hasn't been FDA approved yet, while the gel has. So this is a little bit more, it's the same technology, but just a little bit ahead of time from that perspective. A few last words about Sbrt. So that's the new kid on the block. Sbrt stands for stereotactic body radiotherapy. Basically what it means is a very high dose, very accurate treatment. It has been given in the past only to small brain lesions, small brain masses, but now we are starting to utilize it more and more in the clinic. We're using it for lung disease, for lung cancer that is. We're treating it for liver masses, liver tumors, and now we're also using it for prostate cancer. So we are able to reduce the number of sessions. Previously, patients had to have very little amount of radiation given to them for a protracted course. So that is 30, 35 treatments. But now we're talking about here in Rambam, we're doing it in 5 sessions. So within a week and a half, the patients are done with their treatment. They're very happy with it because it's very convenient to their quality of life. Just one slide regarding the side effects of radiation. So not everything is wonderful, obviously, with radiation treatment. We have also some side effects. The side effects are usually temporary, and they would subside within 3 to 6 months, immediately following the treatment. But in some small number of cases, the effects can be even longer, extended period of time, could be a year or so. The side effects are because of what I just mentioned, because we do affect the bladder, the urethra, so that's the tube that runs the urine from the bladder outside, it runs through the prostate, the rectum or the bowel, which is there, the nerve bundles, so those are responsible for the erectile function. So all those organs might be damaged, might be affected, and as a result of that, the patient might have some side effects like urgent, frequent urination, stinging or burning sensation when the person urinates. Could be some irritative bowel, so loose bowel movements or bloody bowel movements even. We see that as well, decreasing erectile function. Well, about hormonal therapy, you've had a whole talk about that, so I won't go into too much details. I'll just say that testosterone is super critical for all the muscular function. Obviously, the male habitus, the loss of hair, as I can certainly indicate, and erectile function. So all of these are super important. The testosterone is super important for those, and the testosterone is basically produced by a normal, what we call a normal axis. So the brain, when it functions normally, will eventually affect the adrenal gland, but mostly the testes, and they will secrete testosterone into the body. When we talk about hormonal therapy, And we actually talk about anti-hormonal therapy, because what we do is we reduce the patient's testosterone. And the fact that we do that, or the reason we do that, is that because testosterone acts as a survival factor and as a mitotic factor. So it helps cancer survive, it helps cancer grow. And we obviously want to avoid that. So we reduce testosterone in the body to hold the cancer progression. It might even regress the cancer in some cases. And we would incorporate that either with or before or after, and sometimes all of the above with the radiotherapy. We don't do that so much as with surgery. So usually patients who had surgery or they're about to have surgery will not have hormonal therapy as a rule of thumb. So that's pretty much it. I'll just have to conclude with this slide. Like I said, radiation is a high intensity energy. We used it either as an external or internal type of treatment. It kills cancer cells. That's why we call it the therapy, because it's able to kill cancer cells. It's very effective in prostate cancer, low risk prostate, high intermediate metastatic disease. It's either given as internal or external. We've talked about brachytherapy in the machines. And obviously now we have newer technologies to allow us to reduce side effects like the gel, to have a more accurate treatments like the IGRT, and even help patients with their lifestyle. So reduce the number of sessions from 30 to 5. So that's that. Thank you all for your attention.
Thank you very much. That has to be one of the clearest lectures I've been to for a long, long time. At the moment, there doesn't seem to be any questions in the chat thing. Does anybody wish to ask any questions at all at the moment?
So it's either it's very clear or nobody was interested. One of the two.
No, it was fabulous. Really, it was crystal clear. It was. I've been to many lectures in my 49, 50 years of professional life, and that was beautiful. Really excellent. While we're waiting, just in case, maybe you could just give us a very quick idea as to what COVID-19, the effects of that's maybe restricting your ability to provide treatment?
Excellent question. So we are now, as a whole, I would say the whole radiotherapy community are now trying to limit visits to the hospital. So patients are now being treated with less and less long courses, and the courses become shorter and shorter. This has some probably advantages and maybe even a few disadvantages, but definitely in the COVID-19, we want to have patients come less and less to the hospital, and moving from 25 sessions, 20 sessions to 5 sessions, even sometimes 3 sessions is very appealing. We're able to do that in most cases, but not all of them. While in some sectors in the hospital, we've seen some reduced ability to do outpatient procedures. We as a whole decided that this would be, a non-appropriate approach, because for oncological patients, this will only cause a backlog, and eventually we will have to treat all those patients, or it will lead to patients having a more advanced disease or rendering them non-curable. So obviously we wanted to balance that, having optimal treatment and not delaying them with a reduced visits to the hospital.
There are a couple of questions from Jeff Hertz. How would you decide between external and internal treatment, as it seems internal is more specific? Right,
so like I said, there are multiple factors. First of all, the aggressiveness of the disease would be one factor. I would say the disease which is more extensive and tends to spread out from the capsule or extends from the prostate outside, we would shy away from internal radiation, or I would say internal radiation as a sole treatment. We might be able to combine the two, but we will definitely not forfeit the external radiation part, because that will give us the benefit of treating those surrounding areas around the prostate. The internal radiation is very convenient to patient. Like I said, it's an outpatient procedure, painless, so they're very happy with it. But with a very extensive disease, I would probably not use it as a single modality.
Thank you. And from Faye Kingsley, use of brachy treatment as opposed to radical prostatectomies, which is more common and which is more effective short and long term?
So, this is probably hitting the nail on the head. So there's a major debate now, what is more efficient? Is surgery a better way? Is radiation a better way? And when we talk about radiation, is brachytherapy more effective than external beam, or the vice versa? And the jury is still out. There's been some trials trying to evaluate that. And I would say that even looking at the most recent data, we would probably tell most of our patients, again, this is not across the board, but most of our patients, that the oncological outcomes are the same. So having a radical prostatectomy or having a external beam radiation treatment, either with or without hormonal therapy, will lead to the same oncological outcome. Obviously, there's a difference in the profile of side effects. With surgery, the actual effect of the anesthesia, the longer procedure, and the possible blood loss and other complications are a part of prostatectomy, radical prostatectomy. There are different side effects that are related to the urological function of the patient, sexual function. But so this is a very touchy subject. I will just let me answer it like in a general sense. Oncologically, those two are equivocal.
I missed the last part of that, but there's one more question from Karen Pisk. Does aberratarian need radiation?
This is about the abiraterone, which is the CYP17 alpha inhibitor, which is a medication. This is a new hormonal agent or novel hormonal agent. I'm not sure if that's what the question was, but in regards to that, we would now combine that sometimes with radiation therapy, being this as the new kid on the block with probably better ability to affect testosterone. Some patients under abiraterone will need radiation, and some of them no. So this, I guess, unless the question can be more specific, I would probably be able to answer that.
Karen, do you want to unmute yourself and follow that through? No? I think probably the last question is from Brian Luber, which is probably where it would have been at the beginning. What are the symptoms that you have prostate cancer?
Right, so the symptoms for prostate, can you hear me? Am I clear? Yep.
It's a bit wobbly at the moment.
Wobbly? Okay, so I'll try to be as clear as I can. So most patients are diagnosed without symptoms. Most patients are diagnosed just due to either PSA being elevated or due to abnormal physician examination. That would be probably for most patients. I would say that some patients would have urinary problems, that is having a more frequent urination, urgent urination, more urination at night, sometimes painful urination or some burning feeling when they urinate. Well, this is not very common, maybe blood in the urine. The other symptom might be reduced sexual function, so reduced ability to reach erection, maybe reduced erectile function as in shorter erections, or inability to reach erections at all. So while those might be the two most common causes or common symptoms, I would say that most patients are not diagnosed because of these. They're diagnosed because of elevated PSA, which leads them to further evaluation by their urologist or general practitioner.
Thank you.
Hello?
And Karen,
Yeah.
you've unmuted
Yes.
yourself. Do you want to follow that through?
Yes, I'm using Karen's phone. I'm Ian.
Oh, right.
After using abiraterone, when do you not need radiation, and how effective is it in order to get rid of the ailment, or is it purely a holding situation?
Well, it definitely depends on the situation of the disease. So we tend to think that a very widespread disease is currently non-amendable for cure, while very limited spread disease or a disease which is only localized to the prostate, we might still be able to cure the patients. So this in regards to what can be cured or not. In regards to abiraterone, I would say that the use of abiraterone does not negate or leads to the use of radiation. So those are two modalities, and abiraterone will be used mostly for patients with a more systemic disease. So that means that this disease is more widespread, or they have aggressive disease locally, while radiation will probably most commonly used when specific target, when there's a specific lesion, when there's a specific mass, specific tumor that can be treated within the prostate or outside the prostate. So those two are not sort of like they can come together, they can be separated, they can be given without the other as well.
Thank you. Yeah, this has just started to spread outside the capsule in the early stage.
So, what you said was that the cancer spread out from the capsule at the early stage? Is that the question?
Yes. Yes, that's correct.
Yes.
Yeah. So that still is obviously a matter for evaluation by imaging, but we would recommend, even for patients where the disease is localized, even if it's spread outside the capsule, a treatment. Obviously, that would include some sort of hormonal therapy, abiraterone, or other type of medication, and the type of radiation, which would be either external beam radiation or internal radiation, or even combination of both. Many of my patients with a not very big mass, but when it protrudes or sort of like have an extra capsular extension, I would treat with a combination of both.
Much obliged. Thank you.
I would just like to say thank you very much for a brilliant presentation. And I'll hand back to Vered for a final thank you. Vered?
So I would like to thank again Dr. Charas for doing this. It was so interesting. Really appreciate it. And I would like to thank again our partners, Mizrahi Organization and the Jewish Fox Center. And I would like to thank Philip. Thank you for being our moderator, and to our board. And I would like to invite you all to our next Meet the Expert series. And it's going to be on the topic of diabetes. And the first one is going to be with Professor Paul Zimet and with Professor Shahada from Rambam on the topic of diabetes and COVID-19 2 pandemic in coalition. So please save the date, the 22nd of October. And there's going to be another session on the 29th of October, which is going to talk about on the topic of prevention. So just stay tuned, and we will send you the information. Thank you very, very, very much.
And Shana Tova.
And Shana Tova to everyone.
Shana Tova. Thank you, everyone.
Thank you very much, Tomer. Beautiful presentation. And for all of those who don't know, you can follow our meetings and the charitable organization on Osfarm organization in Australia. Thank you all.
Take care.
Thank you, Giora. Australian Friends of Rumba. You can find it on the website. Thank you, everyone. Hope to see you back after the high holidays. Thanks, Philip.
Thank you, Jared. It was
Thank you,
excellent.
Jared. If you're still here, thank you. Thank you. Okay. Bye.
Bye.
Thank you, Alison.